So we just finished talking about endochondral ossification, which would apply to all of the long bones, short bones, some of the irregular bones, sesamoid bones. And now we're going to turn to intramembranous ossification. And this is the kind that we're going to use throughout the lifetime. So if you change the way that you use a limb or you build up muscle mass, then you'd use intramembranous ossification to make the bones more dense, to make more compact bone, and especially more trabecular bone. If you have a fracture, you're using intramembranous ossification to repair that fracture and create a bone that's stronger in that place of injury. So just like happens with endochondral ossification, intramembranous ossification starts at about week 4 with a mesenchyme model. But here, instead of forming a bony collar, what we're going to see is these mesenchymal cells will differentiate into the osteocells. So we don't have cartilage involved in this process. We're going from membrane to bone, or bone within a membrane. So first, we actually start to form the diploi, if this is a cranial bone, or the internal spongy bone if this is the clavicle, because this also applies to the clavicle. In endochondral ossification, we started with compact bone around the diaphysis. So that process is going to continue, and the osteoblasts are laying down matrix. They're creating collagen fibers so that we can calcify, or mineralize rather, calcium and phosphate over a period of a few days. So this process will continue for many, many months, all the way up until about the age of 2. And at the age of 2, the membranous spaces, the fontanelles in a child's head, should have formed suture joints so that bone growth is completed by about the age of 2. In this stage, you can see that as the trabecular bone is being formed, we're also starting, vascularized, you're also starting to form a periosteum, that protective layer that exists around the bone. Deep to the periosteum, then the compact bone starts to be formed. So in conjunction with a discussion about intramembranous ossification, we also have to talk about Wolff's Law. And Wolff's Law says that bones increase in density where there are stresses. So Wolff's Law says that if you are a right-handed person that takes up tennis or takes up pitching in baseball, to use a couple of extreme examples, then as the muscle builds, you'll also see that the bone itself thickens in response to that stress. Bodies don't just fix, they fortify. So if they detect stress, which is what the osteocytes would do for you, then the osteocytes tell the blast, we need to put down more matrix here. We need to make this not just better, but super and stronger, so that we don't have an injury here, because an injury could result in death or being someone else's food. So that's a pretty common principle. If we look at the nervous system, the same is true. The more we use different parts of our brain, the stronger they get. The mechanism is different, but the principle is the same. Same thing for muscles. The more we use muscles, the stronger those muscles get, the more endurance they have. So the principle is the same. The method is just different. Bone growth is regulated by hormones. Growth hormone, which is secreted by the anterior pituitary, is pretty important in stimulating growth of the epiphyseal plate while we're up until about puberty. Thyroid hormones, and there are a couple different kinds, which come from the thyroid, are primarily responsible for normal growth. At their core, thyroid hormones influence BMR, basal metabolic rate. So the rate at which you're building bones, the rate at which you catabolize fatty acids and glucose to make the energy to make more bone. Testosterone, which comes from the testes in men, and estrogens, which come from the ovaries in women, influence when the epiphyseal plate closes. So when that plate is no longer producing more cartilage and will completely ossify. Once it's ossified, it's called an epiphyseal line. And one way to remember that is that lay people will call an epiphyseal plate a growth plate. So if you can remember that, right, they don't call it a growth line, they call it a growth plate. So as you know, calcium is critically important in growing bones. So we're going to talk about two hormones that influence how much calcium is brought into bones and how much calcium is released from bones. So when you're young, calcitonin, or when you're growing bone or repairing bone, calcitonin is the hormone that would be produced primarily. Calcitonin comes from cells called parafollicular or C cells in the thyroid, and you've actually seen these in some of the slides that you looked at for simple cuboidal epithelium. So these calcitonin is supposed to activate osteoblasts and tell them to pull calcium from the bloodstream to the bone. So overall, calcitonin's effects lower blood calcium levels. Now there is some controversy about whether or not calcitonin is particularly effective in humans, but it has been shown to have these effects in other organisms. So for the purposes of our course, we're going to assume that calcitonin works the same way in other animals that it does as it does in humans. Parathyroid hormone is an exceptionally powerful hormone that regulates the increase in blood calcium levels because it effectively tells you, one thing it does, is to cannibalize your own bone. So it stimulates, meaning it binds to the receptors on the cell membrane of osteoclasts and tells those osteoclasts to release lysozyme enzymes and hydrochloric acid, which is then going to dissolve that hydroxyapatite so that calcium ions and phosphate ions can be released back to the bloodstream. This is a classic negative feedback mechanism, and if you need to review negative feedback mechanisms, that's a good idea because they do come up quite frequently throughout the study of human physiology, not just in an A&P course, but particularly in other courses where you may be talking about pharmacology and why you'd want to give a particular medication or a particular treatment. So now that we've talked about how bones grow, let's talk a little bit about what happens when bone fails, and that results in fractures. So a fracture is a break in the bone. So if someone says they had a hairline fracture or they broke a bone, it all goes back to breaking a bone. There's just varying levels of how bad that fracture is. So I will let you read over the terms here, and then we'll talk about a few specific types of fractures. This is a short list of some specific types of fractures. The one that you see here on the left is a comminuted fracture. And the way I remember this one is that it's a complicated fracture. It's where the bone has broken in multiple pieces, and these are the kind of fractures that often require pins, either temporary pins or permanent pins, to hold the bone together. Even though the bone's going to be stronger where the fracture was, sometimes fractures don't heal as perfectly as the original bone, so there's an inherent point of weakness in there. Over here on the left is a compression fracture, which is the one that you see right here. So these are thoracic vertebrae, and I can tell that by looking at the way the spinous process angles down in the x-ray. The ones that are in the cartoon picture here on the left are an area of transition between thoracic and lumbar, so somewhere around like T11, T12. These kind of fractures definitely are not uncommon in people who have osteoporosis and the elderly, because they lose bone density as time goes on. We don't absorb calcium as well. We don't tend to eat foods that are calcium rich as we get older, and the sense of smell and taste start to decline. So in this kind of fracture, what's happened is that this bone, you can see here that white line, that's nice, healthy, dense bone, and then along the inferior edge, nice, healthy, dense bone. In the center would be the spongy bone, and that's what osteoporosis really attacks. It starts to degrade the spongy bone. Certainly compact bone is degraded, but primarily you see the effects with degradation of the spongy bone. And then the weight of the body literally forces these two parts of the body of the vertebra to crush onto each other. Those kind of crush fractures are why you tend to see some elderly women that have a kyphosis or a dowager's hump, that very curved thoracic area. Spiral fractures, not uncommon in athletes, particularly soccer players, tennis players sometimes, football players. Generally, people who are torquing or twisting and potentially are hit from the side. An epiphysial fracture is really a dislocation of the bone. In this case, this is a femur superiorly, tibia, and then fibula, and you can see that the diaphysis of the femur has completely moved posteriorly and inferiorly right here, which looks pretty painful. So those kind of fractures you're only going to see in people whose epiphyseal plates have not yet closed. So for women, that's at about 18. For men, it's about 21. And the last two types of fractures that we'll look at are depressed fractures. And depressed fractures are just that, fractures where the bone depresses into the body. So that might happen with a rib. It certainly can happen here with the zygomatic and the maxilla if someone got a blow to the face or trauma to the face. Greenstick fractures are a type of fracture. It's more like a splintering of the bone. If you've ever taken a green stick from the woods, meaning an immature stick that has green just below the bark, it's because it's a young stick that hasn't built up the tree equivalent of a lot of calcium phosphate. So there's still a lot of water in this bone and in the tree, and if you bend the tree, you can see that it splinters. It doesn't really crack. Kind of the difference that you'd see between the bones in acid and the bones that were baked. So although you're more likely to see a greenstick fracture in a child, it's also possible for you to see it in someone who has osteomalacia, which is a condition of softening, abnormal softening in the bone. Rickets would be the child equivalent of osteomalacia.